We don't sit around the table and talk about death and dying often, right? Or tragedy and serious illness. But there should be moments when we do think about these things because, as you and I both know, life can turn on a dime.
Welcome to Radical Nurse Talk, a podcast that explores nurses' communication in serious situations and illness as a radical act of care. I'm your host, Patricia Strachan. How can we talk with patients and their families about a future that includes living with advancing illness, dying, and death? In today's conversation with Sandra Andreychuk, we talk about advanced care planning, the talk with seriously ill patients and families about the future, and how the widely lauded Serious Illness Conversation program can help nurses listen and respond. Sandra's nursing career has largely focused on supporting patients, families, and community with end-of-life care planning, educating and supporting healthcare professionals on caring with compassion for the dying patient, and navigating the moral, ethical, and legal landscape that people may encounter within the health system. Sandra holds a master's degree in science nursing and a master's degree in health science and bioethics. She worked for 16 years as a pediatric nurse practitioner and over 10 years as a healthcare ethicist. She's a master trainer in the Serious Illness Conversation program, which originated from Ariadne Labs in Boston, Massachusetts. Currently, she is the project manager for the Serious Illness Care Program at Hamilton Health Sciences, leading the implementation of serious illness conversations across the organization. Sandra provides community education on advanced care planning, and in 2020 founded Quality Life Planning, a healthcare consultation service aimed primarily at supporting clients to develop advanced healthcare directives to accompany the power of attorney for personal care offered in Ontario, Canada. Welcome, Sandra. You bring such a rich and unique background to the important work that nurses do. And I'm so grateful that you've agreed to join me and talk about that.
Yeah, absolutely. Thanks for inviting me.
So to begin with, as you look back in your career, I'm wondering if there are conversations that stand out to you or situations that stand out to you as some of the really hard conversations that you've had with patients and or families?
Oh, there's just so many, Pat. Like when I think about the challenges that we face in healthcare, I think one of the biggest challenges is communication. So, in just reflecting on that, I remember I had a situation where when I was working in the newborn intensive care unit, and making decisions for pediatrics is very difficult because they don't really have a voice of their own, right? We depend on the families and we depend on the parents, the health professionals to make decisions for this, very vulnerable, tiny little human being. And I remember that many people were coming in to make recommendations on what they think should happen. And the baby had a lot of different issues going on, with the brain, the heart, the lungs, the kidneys, the bowels. And every specialist came in and said, I can fix this, I can fix this, I can fix this. And nobody was really taking a step back and saying, what's the overall picture here? Like, yes, we can do all of these things. And and everyone's giving their own opinion within their own encapsulated specialty instead of looking at the whole picture. And I think it was a great example of how we were not taking a holistic approach to care. And when we stop and pause and say, who is this person as a whole? I think we have a different lens that we look through because we're not just looking at it through a disease lens. We're looking at it through a humanistic approach. And as that person as an entity and a complete whole versus bits and parts. So I think that, I remember kind of putting my hand up and saying, it feels very odd to me. And it was hard for me to articulate at the time what I was feeling. But I think in hindsight, I can express it now because I think stepping away from it and learning more about communication and our holistic approach to care and, multidisciplinary approach to care, I think that conversation that happened 20 years ago would probably look a lot different today.
Thanks for sharing that and also being humble about your learning in that. How did you learn to have those conversations or to raise your voice as advocate?
Yeah, courage. right? Humility, being able to be vulnerable and put yourself out there and be heard, right? Because I think it does take a lot of courage to put your hand up and say, I don't understand, or help me understand. And by that we learn, right? And I think, if one person's wondering, there's definitely somebody else in the room that's also wondering. And so for you to be the courageous person to put your hand up and say, I need more information. I had also great preceptors. Like when I was working in the neonatal unit, I know you remember back in those days when the nurse practitioner program was just in its initial inception, and McMaster University was really leading the way in this. And so I had some amazing professors, Janet Pinelli, Amanda Symington, like they knew how to really communicate well and how to teach others to do that. So I do credit a lot of my role models in my ability to learn, to be a good communicator, for sure.
That's a good reminder to us to think about the people that are shaping our own practices, and also how we as educators can be more intentional about helping people learn those skills versus having the good fortune of having a mentor. And so you've obviously taken this far beyond where you were 20 years ago. So you've eventually focused on advanced care planning. Can you describe what that is?
Yeah, for sure. So advanced care planning is really a concept in healthcare that looks at reflection of who we are as people and what we would want for ourselves should we find ourselves in a situation where others have to make decisions for us. And it really should be done when somebody is well and healthy, and, young adults should be thinking about these things and sharing them with the people around them. And we often make a lot of assumptions about what others would want for themselves instead of asking. And oftentimes we don't ask because there's not an opportunity. Like we don't sit around the table and talk about death and dying often, right? Or tragedy and serious illness. But there should be moments when we do think about these things, because as you and I both know, life can turn on a dime. It's very important that people understand what we value and what we wish for. That's the concept of advanced care planning. It's about doing this when we're well, when we're healthy, when the conversation doesn't feel so uncomfortable because we're not staring something serious in the eye, whether it be death or a bad prognosis or diagnosis that we, find ourselves in the middle of having to deal with. And so that's sort of the idea of advanced care planning. And we know that the Ministry of Health is very big on this because they want people to have these discussions. Our different colleges, the College of Physicians and Surgeons, the College of Nurses, the College of Social Work, it's all part of that standard of practice that we engage in these early discussions, and we encourage community members to do the same. So that's sort of the idea of advanced care planning, thinking about what our health preferences would be in those what if situations that might arise in life.
So you raised such an important point, and that is that people are almost afraid of doing that. It's sort of like doing your will. So many people avoid doing that as if it would bring on death. And sometimes to me, advanced care planning feels like that.
I guess that, I always will say to people, you don't buy house insurance thinking your house is going to burn down, and we don't buy car insurance thinking, if I buy car insurance tomorrow, I'm going to get in an accident. We just don't do that, right? It's actually mandated that we buy, we insure our property if we have a mortgage, we insure our car if we're going to drive, but nobody's mandating that we have some insurance around what might happen to us should we get sick. And so it's this idea that, is it really taboo, or is it, it's like going on a vacation. You wouldn't plan a vacation and just hope for the best. You do lots of planning around that. We plan for everything. We plan for weddings. We plan for our funerals. We plan for our education. We plan for our vacation. But yet we get scared when we think about planning for our life as it evolves. And in the event that we do face something such as an illness. So it just seems silly that we wouldn't be thinking about these things and doing a little bit of planning around that as well.
So that's a message for all of us, I guess. We all should be doing this and not just doing it in our practice. When you say about planning for a funeral and planning for other things in your life, I've often thought that that gray area in between, we don't talk about.
Yeah.
So people will have very definite ideas about their funeral, but their life prior to that sometimes gets avoided in terms of what they value and wish, etc. So we can be advocates for ourselves as well. So what is the difference between advanced care planning and an advance directive? And we should note that in different countries and in different regions of our country or other countries, this language may be different. Advance directives. Do you want to just talk about that for a minute?
Yeah. And so in a nutshell, it's like a roadmap. So if we think of it that way versus, because I know that we do get caught up on the language, right? And there's been a lot of pushback from people about an advanced directive because they feel that it becomes legally binding. And I can speak in the province of Ontario, advanced directives are not legally binding. Advanced directives are really a tool that the substitute decision maker can use in order to make decisions for the person they have to make a decision for that's incapable. And so they're never really put into play until somebody becomes incapable and the decision maker is like, okay, now what do? I don't know how to make this decision. Oh, I have this tool. I have this roadmap. I have this advanced directive. I'm going to read through it. And that directive should represent the voice of the person. That person should speak to you while you're reading their document, so that you can get a sense of what quality of life means to them, what things they're willing to live with, what things they would see as falling below the level of quality of life that they would find acceptable, and maybe give you a bit of direction about certain specific things that they want for themselves. And so when I help clients create an advanced directive, we go through the advanced care planning process first to get to the development of a directive. So I would never just jump in and do a directive for somebody without knowing them, without having a discussion and asking them several questions. And I know that in some situations, you may go to your lawyer and they have a standard template and you tick off boxes and you sign it and you hand it back to them. The validity of that when somebody is reading it and it looks like a carbon copy or it looks like it could be anybody's voice, it's less important to the person making decisions, or it's less valid to those around us because they're like, yeah, this is just a standard template that everybody uses. But if you do a good directive, you can hear the person's voice when you're reading that directive. It's personalized to them and it gives the decision maker, the substitute decision maker, the ability to feel comfortable in the decisions that they're making for that person.
Right. So it would be true that having a conversation with someone may not necessarily result in the writing of an advanced directive, but at least having that conversation around what's important and what they value is what's really at the essence of this.
Absolutely. And, people get creative too. They can do videos. And they can, do a voice recording. They can have, their friends over for a dinner and play. There's different games that you can buy that actually inspire these questions. It doesn't matter how you do it. What you want to make sure is that you're following this process of engaging in discussions, reflecting on the options that we have within our health system, thinking about, as we age, aging in place, meaning like living at home for as long as possible. Like talk to your family about that, about renovating your home, about, doing an environmental scan to say what in my home, if I aged or if I ever ended up needing a walker or a wheelchair, would I be able to live here? That's all about advanced care planning, thinking about those things. And I mean, there's so much that can go into an advanced directive, which is part of the planning, right? You can think about your funeral. You can think about who you want to share personal health information with. You can think about what your death would look like, the environment you want to be in, the music you want to have played. You can think about what things your health professionals would need to know, like, I wear glasses to see the TV, or I have my second language is Italian, or my first language is Italian. I might revert to that. So these are things that you want to be thinking about and thinking, how would that play out if I ended up in the health system or if I ended up needing somebody to support me? And then start talking about it. And then I mean, the steps, the 5 key steps of advanced care planning. The last one is to document. But I always say to clients, like, if you are not ready to document something, that's okay too, because this going through this process is just as valuable as creating something in the end. It is something that people will often want to create because they've done all that work. But the other thing I'll mention in our health law, so our law is followed by we're governed by the Healthcare Consent Act, the Ontario Healthcare Consent Act. And decision-making for an incapable patient, the way that it reads is that it's the last express wish, verbal or written, that is applicable to the situation that is made well capable. So it doesn't have to be written. It could be verbal. And it could be something that happens right before you go into surgery and you share something with somebody, right? And they can take that and use it to make decisions for you.
So another point is that people can change their minds.
Absolutely. Absolutely.
And as conditions may change, life experience changes people. And then, of course, when people do come into the health system, we never can predict the conditions under which they will require care. So these are just guideposts.
Yep.
And of course, subject to legislation in whatever area people happen to live.
Yeah.
We've talked about advanced care planning. We've talked about advanced directives. How are those different from what we would understand as a goal of care discussion?
Goals of care discussions are often about the options of care that somebody has and to create a plan around the illness. So when you're creating goals of care within the health system, it's usually because you're facing an illness and you need to figure out, how are we going to approach this? What are our options? And this is when we often will see clinicians engage in describing what options are available, what alternatives are available, the pros and cons, and then going through what we would consider an informed consent process, and then coming up with a plan of care. And so that plan of care kind of equates to your goals of care. And so we often see that clinicians will then be very structured in what the goal of care would be. And let's just say, for example, somebody who's fighting cancer, their goal might be cure. So the overall goal is to cure. And so then the plan becomes provide this like A, B, C, D, E intervention to reach that ultimate goal of care. And so that's what I kind of, that's how it sort of fits into these discussions or these different various types of conversations. And the advanced care planning can inform the goals of care because you've already thought about these things in advance, not within the context of the illness that you're facing per se, but in regards to how you like to live life, the things that most worry you. So that then starts to inform your goals of care and how that would unfold.
Okay. So advanced care planning is thinking about the future and possibilities, and goals of care discussions are actually about a plan for an issue that is happening now.
Yeah.
Yes. Thank you. Mm-hmm. Now we're going to thread this conversation with another highlight in your own work, and that is the Serious Illness Conversation Guide. I'm wondering if you can just talk about what that actually is.
Absolutely. So when we think about serious illness and discussions that we have with patients and families, this looks different than goals of care because a lot of people will confuse the two. Well, I had a goals of care conversation, so I don't really need to have a serious illness conversation. So I'm going to go back to the beginning where I said this holistic approach to care, because a person is not just their disease, right? A person is so much more than their disease. It's like the iceberg, right? What we see when we deal with patients and families is just the tip of the iceberg, because we are seeing them within the context of the health system, dealing with their health issue. And so what we need to do is we need to take a step back and say, tell me more about who you are as a person. What are you most worried about? What is your greatest fear? Who are the people that are supporting you through all of this? How much do they know about your illness? How can we continue to improve your quality of living? Yes, we're doing the treatment for, that overall goal, cure, or whatever it might be. But what other things are going to help you live life to the fullest. That's what a serious illness conversation is about. They don't happen very often in the health system, independent of it, in and of itself. It might come up with other things. So when you're doing your initial assessment of a patient and you're understanding what their goals of care are, you might throw in some of these other questions that are about that holistic approach. But a serious illness conversation is about carving out time for that and making it very intentional. And not just throwing it into your day-to-day conversation, but to make it very intentional so that that person knows, I care about you, I'm in this with you, and I want to ensure that I have a really good understanding of who you are as a person. And I'll just give you an example. An example is, I'm going to use a woman with breast cancer. Okay, so a woman with breast cancer, her goal of care is cure. She's, let's say, 40 years old. She's got 3 little kids. And the team knows that we're doing everything we can to, radiation, chemotherapy, surgical intervention. We're going to try and make sure that this cancer goes away and never comes back. You sit down with that woman and you ask her, what are you most worried about? And she says, my children. I can deal with chemo. I can deal with radiation. I'm strong. I'm young. I came into this healthy. But when I look at my 3 little kids, that's where I have a hard time waking up in the morning and not knowing how to tell them why mommy's not here for some of the time, feeling like I've left them and they were too young to understand. So now we might have a different intervention that we're going to help with. Okay. So now we may say, we want to get child life specialists involved. We want to invite your kids to do a tour of the hospital to see where mommy is. We want to work with the team to maybe one of your little kids can stay overnight with you. And the nursing staff can help support that. So now this really stressful, horrible situation this mom's going through is now placated a little bit by us understanding more of what is most concerning to her, because we actually ask the question, what are you most fearful of?
Okay, great example. If we can just go back a little bit, we're talking about a certain conversation that has been coined serious illness conversation. And when many of us hear that now, as this has become more widely known, we know what we're talking about. But in fact, someone could hear that term serious illness conversation and not understand that we're talking about a certain guide that was created. So can you just describe where it came from just briefly? And then we can also point people, if they wish, if they're not familiar with it, to a resource online.
Yeah. Okay. Absolutely. So I'm going to say 2 names, Susan Block and Etoile Gwandi. Okay, so they were the ones that really started this initiative in what is coined Ariadne Labs. And Ariadne Labs is a kind of a test lab for really innovative things that happen in healthcare. They're very world renowned for the innovation that they do. Etoile Gwandi, Being Mortal, if you haven't read it, it's often on people's, best read book list. And so he just went out and said, he asked a number of different clinicians, how do I talk to patients? He was a surgeon. How do I talk to patients when I see them coming into the OR and I'm thinking, oh my goodness, why are we going through surgery for this patient when the outcome is so grim? Has anyone stopped to talk to them? And so gathering all of this information and working with Susan Block, who was a palliative care physician, they came up with this idea of a checklist, which we often use checklists in our health system, right? Like you think about the OR checklist, right? Like we go through everything so we make sure we're doing the right thing. So basically they came up with a checklist, which has become the guide. And this checklist is really leading or guiding your conversation so that you don't miss really important information when you're talking with your patients. So and I'll just kind of go through the highlights of the guide. So it really is about setting the stage, understanding how the patient would like information shared with them, getting an understanding of what their understanding of their prognosis is, and then really exploring some key factors for them, such as what are you most fearful of? What worries you the most? Where are your sources of strength? How much does your family know about your illness? What are abilities that are so crucial to you that you can't imagine ever living without? And then being able to, with that exploration of those things that are not necessarily about their disease, but maybe more about how they're living life, to make some recommendations. And so that my example of, getting child life specialists involved, that's, that would be sort of a recommendation that would come out after this detailed exploration around what's most important to them. And then, ensuring that the patient at the end knows that you're there to support them through this. And then, of course, the final step, documenting, to make sure that all of this great information is transferred to somebody else who might be caring for that person. Yeah, so that's sort of how the guide came about. And, when we talk about a serious illness conversation, it's part of the serious illness care program. And that's the serious illness conversation guide that is the crux or the centerpiece of the program.
So I know that research has shown that the guide is best implemented and taken up with effective results when it is embedded in a system. So that's where the program is.
Yeah.
However, clinicians, and in this case, we're going to focus on nurses, can use the guide and parts of it in their practice without system-wide implementation. Is that correct?
I would absolutely agree with that, Pat.
Okay. And so for those who are not familiar with it, you can Google Ariadne Labs and Serious Illness Conversation Guide, or just Serious Illness Conversation Guide, and it will actually pop up in the search. Yeah. I have actually colleagues in Denmark that told me they were using it, that they had found it on the internet, and that's without the actual program that taught it. So if we can focus a little bit on how nurses have received this and how useful it is to nurses.
Yeah, for sure. So it's interesting because last week I was training nurses in the cancer center. One of the nurses said to me, I feel so lucky to be on the cusp of something so important in our health system. And it was like, yeah, that you're right. This is a pivotal point in how we deliver care, because more people are standing up saying, I want to share with you what I want for myself. And I want somebody to ask me that. And nurses are in a great position to utilize this as part of their toolbox, right? So this is when you talk about maybe it's not part of the system that they're in, but it can be part of their toolbox. And I always say to people that doing the SICK training is not about a communication course, because we already have that embedded into our training programs, right? Like, when we talk about body language, when we talk about asking open-ended questions, when we these are strategies we learn through nursing school on how to communicate. This is different because it's giving you a tool to use a systematic approach to walk through a conversation that in the end is going to help you understand your patient a bit more than what you did when you walked into that room. For that alone, nurses can use it to understand their patients a little bit more and to also be the bridge of communication between the patient and, let's say, their other health professionals, whether that be their physician, their physiotherapist, their nutritionist, because if they're also gathering information, documenting it, then they can share that with the other healthcare members that are part of the circle of care. We all have this role to play in making sure we hear the patient's voice. And because nurses can do this, even when they're doing care, right? And you're holding a conversation with somebody, you can ask these questions that will give you more of a sense of that person and what they want for themselves. So definitely it can be part of their toolbox. And it can be part of their communication with other health professionals as well.
I think you've hit on something really important, and that is that nurses have these conversations usually or very often when they are engaged in some other procedure or care action. And so that time is not carved out specifically necessarily for this. And that is really a part of nurses' work that's not well appreciated or understood, perhaps. So one of the things that people often say when we talk about having conversations that often have an emotional connotation or are serious is, I don't have time for that. How would you respond to that?
I guess, I know there's so many ways I can respond, but I guess I have to admit appreciation for that, because I know it can be very, very busy. But these conversations don't have to take hours and hours, right? I mean, on average, they take about 20 minutes. And in my role as an ethicist, when I was able to sort of look in on a situation, I would always think, I wish somebody would have asked them a year ago what they wanted, because now their family's trying to figure this out and everyone's arguing about what they think the person would want for themselves. And if somebody would have just taken 20 minutes to have this type of conversation with them, it would have saved a lot of hardship in future. It's kind of like this idea of like, solve the problem upstream, right? Work upstream versus trying to, undo the damage or the flood that's happened in the end. And it will save you a lot more work in the end. So I think that it's worth it to carve out the time and to make this part of your workflow. And that's part of the program, is to embed it into your daily workflow. And that's why sometimes it is better to actually designate a specific time for this, even though we can use these as part of our toolbox and as part of our ongoing conversation. But if a patient actually knows that they're coming into this discussion with these questions that might be asked of them, they're going to prepare for it. And that's part of the program too, right? Is the patient letter that you give to them ahead of time. We say letter because it was developed for the outpatient, but it's now been brought into the inpatient. So it's the preparation work that you do with the patient and their family or SDM, so that when they do engage in this conversation, they come prepared. And by that, I mean, they've thought about some of the things that are most important. They may have had a power of attorney that they've created that the team wants them to bring in. They may have done advanced care planning with their family doctor, and we want them to bring that in so that we can use that as part of the conversation. So I think that it's worth carving that time out to make that happen. But again, nurses can do this also during their daily activities with the patient.
And they don't necessarily, if they're working in a system that has not endorsed it, can use bits and pieces of it to really strengthen. So one of the things that I've noticed is that people really like having language to be able to say things.
Yeah.
Can you give an example of some of the language that is offered through this guide that nurses find really helpful? I think you've given a couple. But
for sure. Yeah, for sure. I one of the things that I hand out to nurses when I'm teaching this program is the variety of ways to discuss prognosis. So as we all know that maybe we all don't know this, but you and I both know this, is that people feel very uncomfortable with time-based prognosis. They feel like that's reserved for physicians to do that. So I encourage nurses to think about functional prognosis and also prognosis about uncertainty. So functional, something such as, I wish things were different, but I think this might be as strong as you may feel. And I'd really like to be able to understand where things are at for you. And I'm wondering if we can have a discussion about it. The other way in which you can pose it about uncertainty is, the future is often very uncertain, and we always wish we have a crystal ball to know what might lie ahead. But unfortunately, we don't. And I am worried that this is the strongest that you might feel. And could we discuss this further? Another way in which to engage is, like, to start the conversation is, sometimes we have different tools, right, that we measure people's performance. So such as the palliative care performance, the frailty scale. You may say, I've noticed from the last time I saw you when I was on shift that you seem to be doing a lot more. And I've come in this shift, this, stretch of, let's say, 4 shifts I'm doing, and it really looks like things have changed for you. And I'm wondering, how this has landed for you, and maybe we can discuss it a little bit further. And that kind of leads into the discussion. So you don't need to say, something like, you have days, weeks, or months to live, and we need to get things in order and start creating, our plan B, because I'm worried our plan A isn't working. There's other ways to engage and initiate this discussion based on your concern for what you're observing.
And that's so much in the nurse's role. I can say from my own experience that functional decline and how you framed it has been so helpful for people for families too.
Yeah.
To say just as simple, this may be as strong as they feel.
Yeah.
And I know that for families that I've worked with, I've had people come back and say, that was so helpful to me.
Yeah.
In thinking about the future and what we could be doing. And so if you're wrong, that's great. Things can look better. And it also introduced, it was a way that I could hear that I might need to think about some other things. And they've also told me that they've passed it on to other people and said that.
Yeah.
So it's a gentle way to invite other thinking.
Yeah. The other one,
go ahead.
I was going to say the other one that I share with nurses when I'm teaching them that they've often said, oh, that feels really good, is the statement, if your health was to worsen, what would be your most important goals? And so you're still giving them hope, right? You're not taking away that hope and going, when you get sick, when you get worse, right? It's like, if your health was to worsen, what would be the most important goals that you have? How would that change things for you if you were experiencing a decline? And so you're not, you're still allowing for that window of hope, but also instilling some reality and opportunity to think about the future and what things might look like. I guess the one thing that we haven't mentioned yet is like, who do we use this for? And I don't know if you're going to ask that question, so I'll just pause. But I think that's an important point too, right? Like, who would we feel that would benefit the most from these conversations? One of the big portions of this program is about developing triggers. So we all are very familiar with the surprise question. I say surprise question, and I would say 99% of health professionals know the surprise question is, would you be surprised if this person died in the next year? And if not, they would benefit from palliative services, right? And so
can I interrupt you there? Because I'm not so sure that everybody does know that.
Okay.
So we might be surprised by that. It is true that in the worlds that we function in currently, that has come to be accepted. And at first it was such a rare thing because it is totally based on your expert opinion and not a calculated time-based prognosis. So it's really from you recognize patterns of illness in your experience where you kind of see, I think I know where this is going, or it might be going. And so that has become valued, hasn't it, as a way, a non-scientific way, if some might say, to say, maybe we should have this conversation.
Yeah. So that's one way that we can do that. And that's I often talk about that as your gut reaction, right? What's your gut telling you? And as you said, Pat, when we see often patterns in the patients that we care for, we can sort of make some assumption, right? And that's often what it is it's an assumption and based on knowledge, a skill, and expertise. But there's also an opportunity to look at in your own area of work, what tools would you use that are more objective? So it's not just subjective. And so that everyone can be sort of on the same page. And I think about, because I'm working with the Cancer Center right now, I think about the Cancer Center and the palliative performance scale. If you hit a scale of 50 or less, this would trigger a sick conversation. Sick, we call it sick, serious illness conversation. Or if you have a certain diagnosis that we know the cure rate is very low, that would trigger a conversation. If you're going into third line palliative chemotherapy, that would trigger a conversation. Some people use the frailty scale. I know when I worked with medicine, they were using the frailty scale. So you hit 5 and above, that would trigger multiple hospital admissions within a year with comorbidities would hit a conversation. We have now the what we call the Homer scale. We're not using it in my organization, but in other organizations, they use the Homer scale, which is a very objective way of gathering data from that patient and then making a decision about whether or not that person would trigger a sick conversation. So what the trigger is to be objective so that you can identify patients so that you're not just casting the net wide and having this conversation with everyone. You're actually identifying key patients based on their diagnosis, prognosis, their comorbidities, and making a decision about having carving out time to have this discussion.
Very useful ideas and tools that we could be using. We could be introducing into an organization or just taking up ourselves. So the other thing is, I think nurses are often worried about, is this in my scope of practice?
Yeah. Mm-hmm.
Or if somebody says, no, you don't, we ask for permission or you don't have permission. Yeah. Can you comment about that?
Yeah, I think that is, I want to say, an old way of thinking, right? A mindset that lacks the understanding of this tool, because the tool isn't about sharing prognosis. And I know, our physician colleagues often feel like that's their part of their domain, which is completely true, right? It's not the domain of the nursing practice, our scope of practice, to share diagnosis and prognosis. We might reiterate it because it's been documented, it's been charted, and the patient's been told, and so we may reinforce or reiterate that. But so people then get hung up on, well, because it says sharing prognosis as part of the guide, I can't, this isn't part of my scope. But again, we talked about the different ways in which we identify prognosis. So it's not just time-based. It's not just specific to disease. It's about function. It's about uncertainty in life. Like our aging population, so much uncertainty there, right? And you're seeing UTIs and hospital admissions, decline, more and more comorbidities. This is that's perfect person to be having these discussions with, right? So it doesn't have to be about a specific prognosis. So I think when we wrap our head around that, then we can see where it falls into the nurse's scope of practice. And, again, I'm going to go back to, my colleagues in the cancer center and the nurses there. Part of the a cancer care nurse's scope of practice is end of life conversations. It's right in the scope of practice. So this is a great tool to help enhance their performance around communicating with their patients and families. So it definitely is part of scope of practice. And again, it's different than a goals of care conversation, right? Where you're talking about the options of treating the disease. We're talking about a holistic approach to care. So it is definitely part of the nursing scope of practice.
Thank you for that. I think that some nurses are afraid they might harm the patient by having these conversations or saying something wrong. And so that's very helpful to think this is actually about learning. It's a learning conversation around the patient, and often normalizes the conversation about these things. It's like if the nurse introduces this or picks up on cues to have this talk, it actually feels better to patients. It normalizes. If we can go back to prognosis for a minute, I also just wanted to pick up on that because I think nurses offer prognostic statements all the time. You're doing very well. This is how you may feel in a few days. It's likely many patients like you who have such a diagnosis often feel this way. It's a way to introduce future planning. So really, it's just an extension of that.
Yep. And then delving a little bit more in the exploration, right?
Right.
So I've shared this with you. Now I want to know how you feel. I want to know what your thoughts are, where you want to go from here, right? So it's about sharing that prognosis and then doing further exploration. It's sort of a way to introduce the conversation.
Another term that you used or phrase that you used that I've heard as very helpful is that wish, worry, wonder. Can you briefly talk about that?
Yeah. So wish, worry, wonder is very helpful. I wish things were different for you. I worry that things might get worse. And I'm wondering what this means to you. So you're not taking away hope. You're instilling a sense of, in some ways, comfort by saying you're wondering what that person wants. So you're sharing with them that what they tell you is important to you. And you're also being honest by saying, I'm worried about you. Like, who doesn't want to be somebody to be worried about them, right? Like, you feel taken care of, right? So you've got hope, you've got care, and you've got commitment to be there for them. in that brief statement. And so it does really, I think, help people to phrase it properly.
I think we could take that into different parts of our practice. So think about how you could incorporate that. And that wish, saying I wish, is standing in hope.
Yeah.
Right. Which is something that we never want to take away in
That's
whatever
right.
form
That's right.
that might be in.
Yeah. Yeah. It does seem to be the health professionals' biggest concern, right, is taking away hope. But what I can say about that is that people's hope changes as they experience different things, right? And as time goes on, especially when somebody is facing an illness. And again, we're talking people that likely will not survive their disease, right? So their hope is going to change over time and what they're hoping for. And we should never assume that these conversations would be worse for somebody. In fact, by offering this, we are offering them an opportunity to pause and think about what's most important and what things they want to do and how they want to live life, which if nobody brings this up, that person may walk away and continue to maybe do things that they wouldn't have necessarily done had somebody not been open and honest with them about where things are at for them.
Yes. Thank you so much for this. I'm wondering, as we look to close this conversation, something we could probably talk about for a long time, but what is it that you've mentioned some feedback that you've had from nurses? Is there anything that stands out to you that, in addition, nurses find very helpful or very challenging, or what they need in order to be able to feel confident in having these conversations with patients and families?
I think the program itself, being able to do the role playing, I mean, that's part of the program, right? Is, to practice the tool and even to be able to practice it with your colleague, right? And get feedback from them. But also to play that role as a patient, right? So how did that land on me? I'm playing this role as this patient who has cancer that's, been told really bad news. And now I'm sitting there across from my nurse and geez, this is what I'd really want them to say to me. Well, now you're like, oh, then I should say that to my patients, because if that's how I'm feeling. So to be able to actually, use that simulation, I think is really helpful for nurses. I've heard that they felt very comfortable, very nervous and scared to do it. But then after often saying to me, oh, I'm so glad, that was so helpful. Like, I honestly, Pat, have had very rarely have I had a nurse walk away saying, oh, that was a waste of my time. Like, they often feel really great about being able to utilize the tool in practice. So I think that's often very good for all of us. I mean, we wouldn't go stick a needle in somebody until we've done it on an orange, right? So I think it's, I think it's reasonable to practice it with one another. Again, I'm going to go back to the prognosis. I think that nurses feel somewhat uncomfortable in almost every session that I come in with nursing colleagues will say to me, I don't really feel comfortable with the prognosis. But I think if, we have the interprofessional practice guide, I know that you participated in the development of, which has those other options of prognosis, right? And that's why we sort of threw away the clinician guide that was originally created, because it was really geared for physicians. Whereas the interprofessional practice guide brings in the language for other professionals and not just physicians. So I think, that I think is a really good tool for nurses to sort of look through to see the other types of language. And I would say you do this all the time. It's just being able to bring it all together and to add this as part of your skill set for communicating. Patients, it matters to them when they feel cared for. And they very rarely do I hear people complain about nursing. Maybe it's because I'm a nurse, so they don't want to complain about my colleagues. But, most people say, oh, I got such good care. They took such good care of me and so much good compliments around the physical care that we give. This emotional care is definitely part of our scope of practice. We've often done it for years and years and years informally. And I don't think there's anything wrong in making this a formal process of our practice. So I would say, go for it. It's part of your scope, and it's part of your ability as a nurse to do this.
Thank you. What a wonderful note to end on. That's a very affirming statement about nursing practice. Sandy, thanks so much for taking the time to wander into this conversation with me. I'm wondering if people wanted to contact you or get in touch with you, how might they do that?
So I would say the easiest way is to go onto my website. So it is qualitylifeplanning.com. I think you have to spell it out, because when you Google search it, it doesn't just pop up, because apparently there's lots of other places that have these 3 keywords into it. So so qualitylifeplanning.com.
Thanks for listening. You can reach me or information about this episode on our website, www.radicalnursetalk.com. The producer-editor of this podcast is Jeremy Ramos Foley. Social media by Amy Strachan. If you'd like to support the show, please rate, review, and subscribe. Join me next week for more Radical Nurse Talk. In the meantime, have a radical conversation in your practice. It can change lives.